All right, so welcome everybody to clip session number 11. Wow, it's been a incredible journey for all of you. And it's getting closer to the promised land, which is nice. So tonight is an amazing session. We have Dr. Lauren Redler. Dr. Redler is a phenomenal pediatric, adolescent, and adult sports medicine surgeon. Dr. Redler came to us from Georgetown, where she was an all-star lacrosse player. And she is a unique person because she is one of the, I tell you guys, I've told you over the time of meeting you, that there's certain people that you have the privilege and honor of training in residency that stand out as gifted surgeons. And Dr. Redler is one of the top 3 of all time in the 21 years that I've been doing this. And so she had a skill that was unique and separated her from her peers very early and often, and she's continued in that path. She was an outstanding resident, and then she went to HSS to do an adult sports fellowship and to Boston Children's to do a pediatric and adolescent sports fellowship. And then we were fortunate enough to attract her to come back and join our faculty. She is also unique because she has been able to, in her early career, somehow try to figure out how to be a mom, be a wife, be an orthopedic surgeon, be a physician, be an educator, be a mentor. And I think it's not easy for any of us, but it's certainly not easy when you're a woman trying to do that in this field. So Dr. Redler has a lot of things that she brings to the table, and it's great to have her share some of her thoughts tonight. And as always, she'll share her thoughts for about 40 minutes or so, 45 minutes, and then she'll answer some questions, and then you guys will have your breakout time. Dr. Redler, the floor is yours.
Awesome. Thanks so much. And I know I've met a lot of you guys and maybe just a couple on the phone, but it's nice to at least virtually meet the rest of you. And thanks for being here. So Dr. Levine went through this little bit about me. I grew up in Connecticut, not too far outside the city, in a town called Fairfield, which is known for Fairfield University and Sacred Heart, and also beautiful beaches. And as you mentioned, spent some time down in DC at Georgetown for both undergraduate and medical school. And I think there's some Georgetown alumni in this group, so go Hoyas. And then was lucky enough to train at Columbia for orthopedics. And I give Dr. Levine 100% of the credit for making that decision easy for me. And if you guys have any questions about that, I'd be happy to kind of tell you about the details of that story. Did a sports medicine fellowship and then a pediatric sports medicine fellowship, and then back here at Columbia. And this is me jumping up to the front row right here. So I'm going to talk to you guys tonight about 2 topics that are kind of my passion and near and dear to my heart. Patellofemoral instability is one of them, but especially pediatric ACL injuries, and one of the reasons why I went and did that second fellowship. And I think that's a thing that will be on a lot of your guys' mind in the future on what should my practice look like? How many fellowships do I need? Is this a thing that everyone's doing too now? So I'm always happy to answer the questions about that as well. And I had specific reasons for doing mine. I think there are a lot of great ones and a lot of not so great ones to do a second fellowship. So happy to talk about that as well. So why care? There's a ton of ACL injuries per year. About 3% of these are skeletally immature patients. So that's, upwards of 9,000 kids tearing their ACLs. And for a while, these kids may have been improperly managed. And if they are, they had increased time away from sport, potential growth deformity, growth disturbance, and a huge effect on their psychological and mental well-being. For these kids, they don't have a career, they don't have a family that's part of their identity. Their sport is their life. And so it's devastating, as a lot of you probably know, to get pulled from your sport at such a young age. Treating them in really, really little kids with wide open growth plates is fairly controversial. Should they have surgery? If so, when? What matters more, how old they are versus how old their bones are, chronologic age versus skeletal age. And if you look at these 2 basketball teams here, obviously those little pipsqueaks in the front row who are chronologically the same age as the big guys in the back are obviously developmentally very different. So we need to treat these kids differently. Complications of surgery and non-operative treatment as well. That you get meniscus tears, they can have chondral injury. Again, what graft should we use? What technique should we use? The traditional model for all of these kids before kind of physeal sparing and physeal respecting techniques were developed was to just delay surgery until they reached skeletal maturity, and then you could do a normal ACL reconstruction. This looks like the normal non-operative management that you guys are familiar with: brace, physical therapy, activity modification, which you can imagine is very difficult to do in kids this age. Obviously, this avoids surgery, but it has a lot of disadvantages, most importantly, potential detrimental effects to the long-term health of the knee. So acute injuries have pristine cartilage, intact menisci, or potentially these small tears like you see in this bottom row that are very easily fixable and will heal like gangbusters with an ACL reconstruction, not a big deal. But if we let them go into chronic tears, chronic injuries, they get these irreparable meniscus tears and potential devastating condyle injuries that are not reversible. So I just want to give you guys a brief kind of look into what we do for these very, very young kids. There's lots of debate about the middle group right here, this adolescent group with a kind of a year to 2 years of growth remaining. These older kids, obviously, we just do an adult style reconstruction, but it's these really, really little kids that there's been some debate on the best technique. The most important feature to learn about how to decide how to treat these kids is that the bone age is king. It's really what matters. Because if they're old enough and this growth plate is near enough to closure, then it's okay to drill these tunnels across that growth plate. But if they've got a lot of growth remaining, if you drill these tunnels, particularly this femoral tunnel here, which is eccentric in nature, it's going to have devastating effects on the potential longitudinal growth of that femur and, more importantly, the angular growth. So really important to remember for skeletal maturity that females are 14, males are a little bit later at 16. There's about a centimeter of growth remaining in both the femur and tibia in the last 1 to 2 years. So this is how we get to the cutoff of males of 14 and females of 13. So when do I decide to drill across the physis? So there are some ACL reconstruction surgeons who are transtibial drillers. This is falling out of favor, but there's still lots of them around. And for these guys, because they go more vertically through the femoral physis, they can do this 1 year prior to kind of that massive, growth remaining. And these kids should get an IT band reconstruction if the males are under 12 or females under 11. If you're a medial porter driller, which is how I drill, or an inside out driller with a flip cutter, you're going to violate more of your physis because of the oblique nature of your tunnel. And so you need an extra year of maturity to make sure you're not damaging too much of that growth plate. So for me, the cutoff for transphyseal going across that growth plate, soft tissue graft would be boys at 14, girls at 13. So that means that any boy 13 and under bone age and any girl 13 or under is going to get an IT band in my hands. And how do we decide this? There's this huge atlas of Grulich and Pyle, and do I really have to flip through this whole thing every time I'm going to see one of these kids in my clinic? And the answer is no. If we look at this short and bone age assessment that I find really, really useful, there's really two kind of salient features. For the boys, it's whether or not their distal radius is capped. That's the cutoff of 14 when they can have a transphyseal reconstruction. And for their girls, is that distal phalanx in their thumb closed. So just two important things to remember. This is what capping of the distal radius looks like. If you've never heard of it, it's kind of a weird, concept to think of at first. But at 12, you can see it's very transverse. And by 14, it has this more kind of spherical nature, and that distal radial epiphysis is truly capping on top of that metaphysis. So this patient at 14 can have a transphyseal drilling. Anything younger, these kids need a physeal respecting or physeal sparing technique. Same thing for the girls. This one's obviously a little bit more obvious. So the distal phalanx is open at 11 and closes by 13. So at 13, they can have a transphyseal reconstruction. Younger than this, they can't. So the IT band physeal sparing ACL reconstruction, my partner, Dr. Popkin, will like to mention always whenever we're talking about these, and we do these kind of fun debates back and forth about this topic because he has a different technique that he uses, that this was actually created in Toronto at Sick Kids by Dave McIntosh. Lyle McKayley and Min Coker at Boston Children's really have kind of pioneered modifications, and this is a technique that is mostly done, currently. And this is one of the reasons that I went to Boston Children's to learn this technique. And there's a schematic with some age cutoffs of what this will look like. And I think this is a surgery that a lot of the residents haven't seen, and certainly a lot of you students are likely to have not even heard of before. So I thought it would be cool to share some pictures of what this might look like. So here's a case that I did, an 8-year-old girl. She actually has Ehlers-Danlos. She was diagnosed at age 5 with an ACL tear after some odd injury jumping off of a treadmill, and then unfortunately had a second injury a year later in gym class. Here's the rest of her history. It's not that important. Her exam is very important though. Obviously with Ehlers-Danlos, super, super flexible. So the Bateman-Horan score we'll go through that when we talk about some patellofemoral instability topics. Her knees hyperextend 30 degrees, which is a lot. And with her legs in extension, her tibia on both sides sit completely subluxed anteriorly. So no function of that ACL, which is supposed to keep that tibia posterior. She's got that explosive pivot. So remember back in first year of med school, when you're like, what's a pivot shift? You guys could do this on her. It would be super, super obvious. Here are her x-rays. So obviously a little munchkin, super pipsqueak, wide open growth plates. Here's her hand x-ray. So her chronologic age is 8.5 and her bone age actually lags a little bit behind, but in her no question, she needs something physeal sparing. Her MRI, unfortunately, showing ACL tears as well as medial meniscus tears on both knees. Here's her exam in the operating room. Oh, that's going slow for some reason. You guys got the gist. Very, very unstable. Let's see if we can get that to replay. So this is that Lockman that, you know, someone across the room and, you know, or next to you is going to be able to see that. So here's the incisions for this IT band ACL reconstruction. So our normal scope portals right here, this is the inferior pole of the patella on the top of the tibial tubercle. This is important to mark out because when you make this incision right here to sew the graft to the periosteum, you want to make sure you're not affecting or kind of dissecting over near the tibial tubercle apophysis because you can cause some growth arrest there and cause recurvatum. And then our IT band harvest incision. So this is similar if you guys have ever seen any ACL reconstructions, especially revisions where you're adding a lateral tenodesis or an ALL reconstruction. This is the same type of incision you would use to get that IT band for that. So here's using some cool instruments that you may not have seen either. This is called a meniscotome. So this is traditionally what was used prior to the advent of arthroscopy and was used for open meniscectomies. If you had a meniscus tear, the old treatment used to be just cut the whole thing out, and that's what this was used for. But it makes a really nice tool to be able to harvest a really long part of the IT band, you know, relatively minimally invasively. So you get this long graft right here out of this relatively small incision. So this graft is obviously flat, it gets tubularized and sewn together. Here you can see it whip stitch at the end right here. And then here the finger is behind the lateral femoral condyle. And this big Kelly clamp right here is actually from the medial portal, pushing behind the knee. And this is that over the top position. So if you guys have seen an ACL reconstruction with an over the top guide, this is that over the top position. I think when you see this surgery, that position and that guide finally makes sense to a lot of people. So this graft that was whip stitch is now passed behind the lateral femoral condyle. You can see the graft here in the lateral aspect of the knee, and then the sutures coming through the notch. And now the suture is coming out the medial portal. And then this is the key step right here, is getting this little schnitt underneath the intermeniscal ligament, and then a rasp right here to truly make a nice groove in the epiphysis so you can try to posteriorize the graft as much as possible. This is the sutures that are coming from the over the top positions through the notch, down through the tibial epiphysis and under the intermeniscal ligament. I think this picture is really helpful because it helps the patient and their family understand what will be there, which is the graft, but this is easier to understand. So it's what the sutures are where the graft is going to be. This is what it looks like after pulling that graft through. So here's her IT band. This is the PCL right behind it. And you can see graft now coming out this medial incision next to the tibial tubercle. The graft then gets sewn at the lateral femoral condyle right here. So that's the kind of ALL or extra-articular ligament reconstruction portion of this case. And then it's sewn here to the tibia. And this is a really, really fantastic graft, a really fun surgery that can be done very quickly. There's no bone drilling. And here's a final appearance. These are not my images, but this is a kid who had a repeat injury who needed an MRI for something else and a second look arthroscopy, so showing that IT band truly looks like an actual ACL, which is impressive. And this is, the same orientation. There's some studies out of Boston Children's that show that this graft does grow with the kids. So there's some initial concern that if you do this on a little 8-year-old, what's going to happen when they're 12 or 15 or even 20, but that this graft does grow with them. So it is really a really versatile graft. Biomechanically, it's been shown that it reestablishes the translational and rotational stability, most similar to an intact ACL compared to some other all epiphyseal or kind of physeal sparing techniques. And it doesn't over constrain the knee, which is really important. Here's the clinical outcomes for a long time. So this is the original paper that was published in 2005 by the Boston Children's Group. This was for a long time the only long-term outcome that was published. And so one of the kind of things against it was that it was all single institution data. They quoted a 4.5% revision rate, which is a little bit lower than the kind of Moon and Mars data will quote for adult ACL reconstructions. This is another group out of Atlanta that showed that they had a 14% revision rate. maybe it's a learning curve, maybe a slightly different patient population. The same group out of Boston just a couple of years ago published their follow-up data, so a little bit longer outcome, and their graft rupture rate was more in line with the Moon data, around 6%. So this speaks to that potential that there's a learning curve. You know, these are the people that pioneered this technique and they have the best results in the literature so far, but still there's only those two kind of big outcome studies. This is a study that we did at Columbia. Dr. Popkin spearheaded this with myself and Dr. Ahmad and some of our residents. You'll see alumni on here. You'll see the PRISM group is Pediatric Research in Sports Medicine. If you guys have any interest in sports medicine and specifically pediatrics, this is a great group to join. Lots of med students and residents are in it, and I highly recommend. And it's just interesting to see, even in a group that is purely dedicated to pediatric sports medicine, if we presented a case of an 8-year-old boy with a complete ACL tear, so similar to the one I just showed you, still only about half of them are going to use an IT band. So there's still lots of, you know, diversity in the techniques used. Dr. Popkin, for example, really is in favor of this epiphyseal technique. So what are the drawbacks? Certainly, you're going to have a large amount of asymmetry. So IT band is what's kind of keeping that vastus lateralis, you know, hidden more or less on the lateral aspect of the leg. So if you take most of or all of the IT band, which you might in some of these very small patients, you're going to have an asymmetry. So here's a patient. You can see the IT band harvest incision down here on the lateral aspect of the knee, and this vastus lateralis is relatively large, and compared to the other side, which is a little bit cut off, it's more prominent. But when patients and families were surveyed about this, only about a third of them who had this asymmetry were dissatisfied. So this is useful information to be able to share. More in patients, this is likely to happen, but it's probably not going to be a big deal. And then really it's this learning curve. Who's teaching patients or surgeons to do the surgery, and how many does it take for them to get good so that they have the low revision rates that the Boston Children's folks had. So I think something else that's important, and I love to talk about, the residents could attest to this, is billing and coding and CPT codes, and something that you guys will eventually get well versed in. But I think it's helpful to kind of see the codes and what that means and what the relative work RVUs are for that. So this is kind of how we compare codes to each other and how much credit you get for it, more or less. Most important for this case is that because you're doing that extra-articular component of the ACL reconstruction, is don't forget to code for that ALL component of extra-articular ligament. So there's a separate code that if you look at the ACL is 14 RVUs, and that second part of the procedure, which is, you know, by nature part of this technique, is another 9. So important not to kind of leave that on the table. So switching gears a little bit, that was a whirlwind run through IT band ACLs. Probably my favorite surgery, and my second favorite is this, patellofemoral instability and medial patellofemoral ligament. So I trained for sports medicine at Special Surgery, and Beth Schumanstein, who's Chris Ahmad's wife, was my mentor there, and she is an absolute guru in this, and I owe a lot of my knowledge and kind of passion for this subject to her. First off, here's a soccer player with a patellar instability, and this is not how you should reduce it or ever advise a athlete to reduce it. If some of you guys have ever done this in the emergency room, it's rare for them to actually get to the ER. But if you just lift the heel up and kind of passively extend the knee, the patella usually goes back in. So what's the natural history? Of the 100,000 that happen, it's about 6 patients per 100,000 that are going to have a patellar instability event. So it's not that common. Of those 6, only 1 of them is likely to recur, but 2 of them are going to have symptoms. The other 3 are likely to be asymptomatic, and up to about half of those kids are not going to return to sports. The redislocation rate is varied by age, so the younger you are, the more likely you are to redislocate again. And if you've had a prior dislocation, then you're much more likely to have a second dislocation. So the number jumps up significantly if you've already had one. And that's true whether it was on the contralateral side or the ipsilateral side. So if we look at what else puts a patient at risk, females are much more likely to have a patellar instability event, and they're more likely to have a prior patellar instability event. So it's probably why they're kind of, you know, double hit in terms of their risk factors. This is just like ACLs. There's a lot of different factors that go into why they're more at risk that are not completely understood, but we know that they're much more likely to be a patient with patellar instability. If you have a prior instability episode, you're 7 times more likely to have another episode. And open physes, this is what makes it pertinent to this talk, is that this is a huge risk for a recurrent dislocation. Ligamentous laxity, and we'll go through this Baton-Horan score a little bit, is also a huge player. And almost all of these players have some component of hypermobility. if you guys have not seen this before, and half of you guys are probably sitting there getting their, fifth MCP, hyperextended back, or your thumb to your forearm, and a lot of patients actually don't realize that they could do these things before somebody examines them. Other things are important, like trochlear dysplasia. What does the groove look like? Is it abnormally shaped? Is their patella too high? And what's their Q angle like? And what's that kind of force on the patella? Is there a lateral vector just by nature of where the tibiotubercle attachment is located? And then femoral aneurysm. I think this is something that's not quite as well understood, and it's not commonly discussed because the solution is not that easy. And a lot of patients get away with just normal kind of MPFL reconstruction techniques despite having femoral aneurysm. But this is something that I think is becoming more in vogue to address and to potentially even do at the same time with a derotational femoral osteotomy. I'm excited that we have Katie Rosenwasser back at Columbia now. So she was one of our prior residents that I trained with while I was a resident. And she's gone on to do pediatric subspecialty training as well as limb deformity. And we were just talking about a case just this past week on Thursday. Actually, I have a patient with recurrent patellar instability whose MRI shows crazy femoral aneurysm or internal rotation, and we assume aneurysm. So we're getting a CT scan and planning on doing an awesome combo case. So here's some more about de jure classification for trochlear dysplasia. If you guys have never heard about it before, this is what a normal patellofemoral joint looks like. So that axial cut on the MRI that for most parts, most people kind of overlook this unless you're a patellofemoral surgeon. This is where I look first. So that patella really being a V-shaped bone sitting in that V-shaped groove, and it should match. So you have some bony congruity there. The ligament is really important, and it's most important kind of before that patella engages in the groove, but the bony congruity really gives a lot of stability to this part of the knee. De jure A, trochlear dysplasia, so an abnormal shape. This is just a little bit shallow. De jure B is where it's flat, so obviously very difficult to keep a patella kind of, centered on a flat surface. De jure C has this kind of slope on the lateral side, and I used to think that this should help contain the patella, and it was very confusing to me at first when I learned it, why this would contribute to instability. But if you think of it more like a ski jump, and this ramp on the lateral aspect of the trochlea is just kind of launching the patella out, it makes sense why it contributes to instability. And then de jure D, this is kind of the most high grade one and the one that has other things that we think about doing for it. It has this true cliff, and obviously it would be very hard to keep a patella anywhere stable on this cliff that just wants to kick it out over into the gutter. So looking more closely at the natural history and redislocation rates, Chantal Parikh at Cincinnati Children's did a really great study looking at kind of all of the different factors and which of those contributed most to the recurrence rate. The study is a little bit flawed because it didn't have ligamentous laxity, and they don't have MRI data, so it was just a physical exam and x-rays. So probably we could even delve kind of deeper into this and get a better score. I like to think about this like the Coker criteria for hip infections versus toxic conjunctivitis. So how many of these risk factors patients have and what's the likelihood of it happening again? So I use these numbers in my office all the time with patients and their families. And if you have 2 of these risk factors that are listed here, you have a 55% chance of having something, this, patella dislocation happen again. And I think almost any patient and their family presented with that data would rather do something, even if it was surgery, to help prevent that redislocation. And certainly if you have 3 or 4 of these risk factors, almost everybody with a 75 or 88% chance of this happening again is going to choose surgery. So thinking about the anatomy of the MPFL, a lot of you guys have never heard of it. It attaches on the medial border of the patella. There's some attachments to the VMO, the vastus medialis, so the medial part of the quad, and it inserts on the distal femur just between the adductor tubercle and the medial condyle. In this position, these bony landmarks are really important for helping to find that location intraoperatively. And as one of the kind of most common mistakes made in MPFL reconstruction is that this point right here, the Schottle's point, where it's supposed to be attached, and this is what the x-ray looks like of finding it, is often placed too anterior or too proximal. And then you imagine as the patella is trying to make its way around the femoral condyle, that if that ligament attachment is too anterior or too proximal, it's going to be very, very tight. And one of 2 things is going to happen. Either that patient is going to lose flexion, so they don't have really good range of motion, or that graft is just going to pop and break. It's going to fail. They'll have a recurrent instability event. And this is not an uncommon story. I had my MPFL done. I was really tight. The therapist was working with me, trying to get my motion back. All of a sudden, my motion was great, but now I've dislocated again. So this point is really, really important.
Lauren?
Yes?
Can I ask you a question?
Yes.
this is the thing
Of
that's
course.
it's probably tested the most, right? Our residents get this question on in training and boards. Why do surgeons not understand where to put that point? What do you think happens intraoperatively or radiographically, or what's your experience for in all the revisions you do? Why do you think that this happens so much?
Absolutely. I think this is that's a great point, and something that we think of all the time when we're doing this, and you want that perfect X-ray, and I think that's the number one culprit. Is you get an okay X-ray and you're like, oh, that's probably fine, and it's amazing how much this point moves. You can see on this X-ray right here that the condyles are almost perfectly overlapped. They're different sizes, and the medial femoral condyle here is going to be slightly more distal because the medial tibial plateau is more distal. But posteriorly here, these are perfectly overlapped with each other or superimposed, and that's a very difficult X-ray to get in the OR. Having a good X-ray tech is great. Doing this over a triangle is really helpful, but if you accept a slightly less than perfect X-ray, it can put this point off a lot. The other reason I think that this point is sometimes difficult to get is how you're marking it. So if you hold a drill to this point, and the X-ray looks good, and then you go and advance the drill, it's very possible that that drill moves. The alternative that a lot of people do is that they put the drill into the femur a little bit, and then they take an X-ray, but then it's not so obvious. Well, is Schottle's point at the tip of the drill? Do we think that the drill is entering the bone, a few millimeters, a few centimeters from the tip? Where exactly is that? So a trick that I learned in training is to advance the drill into the femur, and then place anything. Usually it's another reamer, another drill, anything that's bigger than that drill bit over the back of it and clamp it so it's tight right next to the femur. So now you've got a size difference. So you go from your skinny kind of guide drill to the actual reamer, and so you can see exactly where that point is entering the bone and helps get this point much more specifically.
Thanks.
So moving on to exam, this is a paper that Dr. Ahmad published, and it's an exam maneuver that I think anybody who does patellofemoral surgery and patellofemoral instability, or treats patients with patellofemoral instability, does. This is called a moving patellar apprehension test. So in part one over here, this patient's left leg right here is kind of bent a little bit over the side of the examining room table. Dr. Ahmad has a medial force on the patella right here, pushing the patella out laterally, and as he bends, if a patient has had patellar instability, they will not let you do this. Patellar apprehension is real. And I always tell my patients that this doesn't make them wimps. This doesn't mean that they're, not tough, that, they have that grimace, that look on their face like you're about to dislocate a patella, and they don't want to let you do that. They'll actually fire their quads and prevent you from doing that when you try this maneuver. And then part two is you give a kind of locating force, so pushing on the lateral aspect of that patella. And now all of a sudden they'll let you flex, as far as you want, and it's not going to bother them at all. So this is a really helpful exam maneuver that Dr. Ahmad published. Looking at a J sign, so this is a patient of mine who had prior surgery on her left knee and came to me with right knee patellar instability. As she's extending, you can see her patella jumping out of her groove. This has to do with the fact that she's torn the MPFL on this side, but also due to the fact that she most likely has trochlear dysplasia. So even with an intact ligament, patients with trochlear dysplasia will have a J sign. So it's helpful if they've only injured one side to examine the other side and see if they have a J sign there. And then without even looking at imaging yet, you have an idea, looking at those risk factors that I shared before with Dr. Preek's study, and trochlear dysplasia being one of those 4 risk factors, you can say right off the bat, you've got open growth plates, you have trochlear dysplasia because you've got a J sign on your other side. So minimum, you have a 55% chance of redislocating. Is really helpful to kind of counsel these patients and their families. Increased lateral patellar translation. So this is a patient who had a prior MPFL surgery and tibial-tubercle transfer, and you can see still has a very unstable patella. And this is even in flexion, the patella will dislocate. This is not what you want your post-op patellar stabilization patients to look like. And then ligamentous laxity, so the Bate and Horan score. So that thumb to the forearm, bending your pinky back at the 5th MCP, it has to be more than 90. And then C and D down here are elbow and knee hyperextension, and then palm to the floor. I always like to demonstrate this one to the patients because I am a 0 out of 9 Bate and Horan score, and I can touch maybe just to the top of my tibias. And they always get a little bit of a laugh out of that. But I'm always impressed when patients are able to do this, and more so when they don't realize that they could do it until I ask them to do it in my office. And then alignment. So this patient has valgus knees. Her Q angles are really, really high. She may even have really lateral insertions of her patellar tendon on her tibia, and that's all going to contribute to this lateral vector. If you think about the force on the patella, kind of no matter what she does, there's a force trying to push her patella out here. And then how do we diagnose an MPFL tear? So imaging. So we can see lots of different tear patterns. It doesn't really matter where it tears, what the tear pattern looks like. There are some imaging where the MPFL actually looks intact. And in those, we tend to think about it, instead of being an actual tear kind of split down the middle, that the ligament is just stretching. And it doesn't matter that that is not a true tear on the MPFL, because that, I mean, on the MRI, because that MPFL is not going to work. I tell my patients that it's kind of like a leash on your dog that's in your yard, and you have a fence, but someone left the gate open. And if that leash all of a sudden is too long, your dog's going to be able to get out of that fence. And so if the MPFL is stretched from an injury, from a dislocation, it's not going to help keep that dog or that patella in the yard, which is the groove, even if it looks quote unquote intact on an MRI. So here's a MPFL patient that I want to present to you guys. This is a 14-year-old ligamentously lax. So he had 6 out of 9 for his Peyton Horan score. He's had 4 dislocations. The most recent one was playing soccer. He's got trochlear dysplasia. His growth plates are wide open. So you can tell this kid that he's upwards of 90+% that he's going to redislocate. I think any kid in this situation is going to choose surgery rather than keep having dislocations, most importantly to prevent potential future cartilage injuries on the patella. So here's what his sunrise x-ray looks like. He's got a little avulsion here off of the medial patella. Importantly, this is not an intra-articular loose body. MPFL is an extra-articular ligament, but this is commonly seen on x-ray. And on his x-ray, you can actually see his trochlear dysplasia. This is not that common. Often you need an MRI to be able to see it. You can see bone age right here. So obviously skeletally mature. His distal radius is starting to cap. This is not as important for the patella insertion, but very important for the femoral insertion. It doesn't change where we put it, but it changes how we drill it. So here's a schematic of what it looks like when a patient dislocates their patella. This is the lateral aspect. Here's the medial aspect. When the patella dislocates laterally, the medial aspect of the patella impacts the lateral aspect of the femur, and you get this impaction bruising pattern that's very classic. And you can knock a big piece of bone and cartilage off right here. And that's really key when you have a first-time dislocator, that you're looking for that big piece of bone and cartilage or an osteochondral fracture that breaks off, because that would be an indication that the patient would require surgery to try to save that piece, to put it back, and or just to remove it so it's not floating around, regardless of the fact that it's their first dislocation. So here's this patient's MRI, classic bone bruise pattern on the medial patella and the lateral femur, and here on the patella. And then here's what a schematic of a physeal sparing MPFL reconstruction looks like. So this point right here on the femur, this is still Schottle's point. There's been great anatomy studies that show that Schottle's point and the native insertion of the MPFL is in fact distal to the distal femoral physis. When we drill, we often place a guide wire through this point and proximally through the kind of anterolateral femoral cortex as a pull-through technique. And you can't do that with these kids because you can't go through this medial aspect of the distal femoral physis. So instead you use this technique. So this is what the x-rays look like intra-op. Here's that AP, and you really need this inclination angle right here to match that kind of undulating distal femoral physis right here. In adult style MPFL reconstructions, you do not need this view at all. The AP doesn't matter for anything. In pediatric patients, this is really important so that you can make sure that you're truly distal. Because the distal femoral physis kind of undulates like this, on the lateral, it might look like you're proximal when you're not actually proximal, because this point right here, see if we can get my cursor back, right here is proximal to this part of the physis, but is distal to here, which is what matters. And here's that lateral view and that tip that I was telling you about before with the drill guide and the drill bit. So here's that drill bit right here, and you can't tell where this drill bit is entering bone, except here's the drill, the actual drill that's on the back of it with a big Kelly that's holding it. And you can see at the junction between the small drill bit and the drill itself right here that that's where it's entering the bone. And this is what's at Schottle's point on this, nearly perfect lateral. And this is the view that you want to try to get in the OR. You can see right here behind this kid's knee is a triangle. And I think that this really does help get that perfect view and kind of make it so that you do the same maneuver every time when you're trying to get this x-ray. So here are some intraoperative scope pictures of a patient, not the one I just showed, but one with a big osteochondral fracture. you put the camera in and here's the undersurface of the patella and that nice kind of shiny white surface of the cartilage. And then there's this funny looking thing right here. I don't know, maybe it's okay. It's kind of flush and, you know, near what the other cartilage looks like, but it looks a little funny. But you open up and this is what it looks like. So there's this massive area of missing bone and cartilage. This is after we already started to treat it. So we kind of microfractured the base to try to augment healing. This is what that piece looked like. So this was another teenager, very, very young. And this piece is huge, 15 millimeters. This is what it looks like going back in. And unfortunately, obviously, you could see lots of fissures in this cartilage. So this patient has had multiple dislocations. And it was this final dislocation that knocked this big piece off. So holding it in place here with a K-wire, and then here's what it looks like fixed with some smart nails and a biocompression screw. Not perfect, but great for her. And I actually had the benefit of going back into her knee for a meniscus injury about a year and a half later and got to see what this cartilage looked like, and it looked beautiful. So it's good to be young. Here's what her final reconstruction looked like. So you can see this kind of Y-shaped graft coming off of the patella down here and inserting down in the femur. She had a little bit of a bigger incision here because of that cartilage work on her patella. But if you don't need that access to the intra-articular space, this incision can be very, very small. And she's got a hamstring harvest incision on here because I used autograft. I now almost exclusively use allograft unless a patient specifically wants autograft, but these patients tend to be very ligamentously lax and stretchy. And we worry about their hamstrings being more lax and stretching out more than an allograft would. And it also saves them some morbidity of the surgery as well. So what about post-op rehab? So a couple of residents and a prior medical student from Columbia who's now up at the Harvard program, Harry did a study looking at variability in post-op rehab. So if we looked at all of the, kind of academic programs across the country and their physical therapy protocols that were publicly accessible, what did they look like? And there was huge variations in the group from Columbia. Some of the residents and some of my partners over the past couple of years have done this study with other factors too, like hip arthroscopy, meniscus repair, Tommy John surgery. So physical therapy protocols vary widely. And I think this has a big component of, a big effect on how patients do and the success rate at getting patients back to sport and the re-tear rate of some of these graft reconstructions. And then what about return to play? So this is something that I think goes across both subjects with ACL reconstruction and with MPFL reconstruction. And it's something that I don't think we're very good at addressing preoperatively and certainly not great at addressing at the quote unquote clearance visit, and we're getting better. But this is looking at clinical outcomes and patients going back to sport after MPFL. Patients with patellar instability tend not to be as athletic as those that tear their ACL, but they still do play sports. And this is showing that 47% did go back, but they went to a lower level. So they may have dropped down from varsity to now just club, or they were playing a club sport and now they're just playing recreational. And the reasons that kids give are enlightening. So about a quarter of them feel like their knee just doesn't work as well anymore. Half of them are scared they're going to get re-injured. And another third just don't have an interest or time. So obviously that's going to happen as kids age out, right? If you were playing senior and high school soccer team and you tore your MPFL and you go to college and you weren't ever going to play, that's some of those kids that are there. But huge effect on the level of play, and the fear component, I think, is a big deal. And this is looking at a similar study, but patients that also included tibiotubercle osteotomy, so still a large number of patients that are just afraid to go back. This is this questionnaire called the RSI, and I am really interested in this subject, and it's something that Kate Webster, who's a researcher who's done a lot of work on ACL reconstructions and kind of risk stratification from Australia. This is a study shortening that RSI, or return to sport after injury questionnaire, from 12 questions to 6 questions. So it's very, very easy to do. And it factors in patients' emotions about going back to play, their confidence in their performance, and also their appraisal of the risk of going back to play. And it's pretty clear that if you test these kids at 6 months and they score over 60, they're very likely to be back playing sports at a year. And if they test under 39, they're very unlikely to go back. And so I think if you give this test, and again, it's only 6 questions to ACL patients at 6 months, it can help guide them on maybe they need a little bit longer. So if they're scoring low at 6 months, you're not going to promise that kid, oh, you're going to be back playing in 9 months. They might need 18 months to go back. And I always tell patients, whether it's an ACL or an MPFL, that there's two components to the return. There's the physical readiness. There's the how did I do in making you a new ligament. There's the how did you rehab, how does your knee feel today? And then there's the psychological readiness. And those two things never happen at the same time. And almost 100% that psychological readiness happens after the physical readiness. And it doesn't mean that they're a wimp and that they're weak. It's just a real component of injury recovery that I don't think we've understood yet very well. This is something that only exists so far validated in the ACL literature, and that we are currently doing a study trying to validate specifically to MPFL reconstructions, changing the wording of the questions a little bit to, instead of injuring your knee or tearing your ACL, specific things about dislocating your patella. And obviously that crosses more than just athletics, it's even in everyday life. You know, are you afraid to take the stairs in high school because you think you're going to dislocate your patella? So we're working on making those questions now and validating it. And I think it will be a really helpful tool in guiding these patients back to kind of getting back into their normal life. Just like the ACL, I think coding is important. So when you do the scope for these MPFLs, almost always there's something cartilage damage, so you code for your chondroplasty. This extra-articular ligament reconstruction, I left this here as an ALL reconstruction. This is the same code that we use for the ACL extra-articular component. So it's any extra-articular knee ligament, including the MPFL. This is the same you would use for an MCL. But importantly for MPFLs, there's a second code that's for reconstructing the dislocating patella, which is what you do kind of on your way out and plicating that medial retinaculum and advancing that VMO to try to dynamize your graft and get some more control on that patella. That's important not to miss, because you can see here that it's the same number of RVUs or about the same as your actual ligament reconstruction. So don't forget to include that one. So some take-home points as we are reaching nearly the 45-minute mark. ACL tears and patella instability are very, very common in adolescent athletes. We always recommend ACL reconstruction to prevent irreparable damage. We almost always recommend MPFL reconstruction to prevent similar chondral injury, only if they have a high chance of recurrent instability. I'm actually part of a multi-center study called Jupiter right now, which is about 15 sites across the country looking at specifically this with recurrent instability compared to first-time dislocators in both the adolescent patient population and the adult population. And should we be operating earlier, right? You would never see an ACL patient right now and say, no, you can just rehab it, you'll be fine. But all the time, MPFL patients are getting told, we don't think you need it, and then maybe going on to getting a second dislocation and tearing. So should we be more aggressive with these kids? And that's what we're looking at right now. And then for both cases, there's special considerations for how you do the surgery to avoid damage to the growth plate. With the ACL, with the really, really young kids, going up and around the distal femur so that you're not drilling at all. And with the MPFL reconstruction, going distal to that femoral physis, still having your femoral insertion at Schottle's point, but really keeping it distal so that you're not affecting that growth plate. So physical sparing for both. Here's me and my family. These are my two daughters. This picture is a little bit outdated. So Parker right here will be 3 at the end of January. And this is Quinn, who's 15 months right now. This was back when she was about 2 months right now, but they are both still just as cute and hilarious. And here's my email. If you guys don't have it, it's just Lauren.Redler, first name, last name at Columbia. Shoot me an email anytime. Happy to answer any questions.
Awesome, Lauren. Yeah, great gallery. Any questions for Dr. Redler? We have a few minutes before you guys go off to your breakouts.
I have a question. Thank you, Dr. Redler. That's very interesting. I kind of have a two-part question. One is, do you find in some of your patients with like pretty severe trochlear dysplasia, like a high level of de Jour classification, that MPFL construction alone maybe isn't enough, or they're more likely to fail that operation? And the second part being, is there a role in your practice at all for trochleoplasty? I know those surgeries are kind of early and limited in their outcomes, but I wonder in some of these patients with severe dysplasia if there is a defined role for that, or maybe not yet.
Yeah, absolutely. You sound like you're someone who has seen some of these. So that's awesome, because there's not a lot of, I certainly didn't see any as a medical student. So it's awesome that you already had some exposure to it. So the first question about trochlear dysplasia, Bess Rubenstein, who's another Columbia alum, also published a study looking at isolated MPFLs kind of regardless of what the rest of the anatomy looks like. Is patella height too high? Is the TTG very, very lateral? And do they have trochlear dysplasia? And they actually do surprisingly well. It's not perfect, and the recurrence rates are a little bit higher than if they didn't have those numbers, but we think that you can actually get away with it. In terms of counseling patients, you have to tell them that they're still going to have a J sign, because all of a sudden post-op, if you don't address some of that and they straighten their knee and they see that J sign, they think something went wrong or you failed. But it's helpful to show them on their other knee that they still have that J sign, and it's because of that trochlear dysplasia, and you're not doing anything to address that. In terms of trochleoplasty, I've done a couple in cadavers. I think it's gaining popularity. Dave Dudek at UVA is doing a lot, and Diane Dom at Mayo is doing some too. Most patellofemoral surgeons in the US think of it more as a salvage procedure and a kind of bailout. What do you do with a kid who has already had 1, maybe 2 reconstructions? They had a tibial osteotomy and they're still dislocating. And the reason is that the patients do well, that you don't need to do it. And so it's this huge surgery, a big undertaking. If it fails, it's catastrophic. So if you've never seen one before, for those that you haven't, I have some cool pictures of it. You basically cut underneath the trochlear chondral surface, kind of wedge out some bone, cut the middle of the trochlear cartilage, and then let that cartilage, which was flat or even domed, kind of fall into a groove. And you leave like a little thin layer of subchondral bone attached to that cartilage flap. And there's thin flap and thick flap, but there's bone underneath that flap. And then you need that to heal. And if it doesn't heal, that's catastrophic. Their entire trochlea is gone. So it's a big risk, big reward procedure. So for a lot of people, for that reason, it's not used. They're very aggressive in Europe in doing it primarily, but I don't think we've gotten brave enough here to start doing that.
Thank you.
Question, Ben. Any other questions for Dr. Redler?
I have a question. Hi, Dr. Redler. Thank you so much
Hi.
for the talk. That was awesome. You mentioned using exclusively allograft for the patellofemoral instability patients because their autografts might be too lax for an MPFL reconstruction. I'm wondering if this has any bearing in outcomes for ACL patients that have a high Baton-Holland score, if you might check that before using an autograft for an ACL or younger ACL patient, or if there's any kind of research looking into outcomes in those patients.
That's a really great question. I think, especially in the young kids where you kind of have to use a soft tissue graft, you obviously worry about that. As someone who does a lot of patellofemoral instability surgery, I check a Baton score on all of my patients. So I think that's helpful to kind of counsel them. But on the physeal sparing or physeal respecting techniques where you have to use a soft tissue graft, you kind of don't have a choice. And different for ACLs versus MPFLs, because that graft is intra-articular, there's something different about that space. And if you use an allograft on those young patients, they have upwards of 25, even 30% re-tear rates. And we haven't seen those same re-tear rates with allograft in young patients where that ligament is extra-articular. So we can, quote unquote, get away with it in patellofemoral instability surgery where you don't have that option for ACL surgery. So it might be helpful to counsel them, but you don't really have a solution for it.
Thanks.
Great question, Allie. One more question I think we have time for. Anyone else?
I have a quick one, if that's okay. Hey, Dr. Redler. So my question is about, you talked about the psychological readiness with ACL reconstructions. I know that's been like an expanding field. I'm wondering, what do you think, or what have you seen in terms of interventions, especially responsibilities for the orthopedic surgeon, if there is some, to improve on the psychological readiness? And
yeah, absolutely. Rob, nice to meet you. I haven't met you before, but great question. So I think it's all about resources. Tishan Lynch, who I think probably all of you have met, who's the associate program director, is a team physician for Fordham. Dr. Levine, who's for Columbia, and I'm sure that they've got the same kind of setup. And Dr. Lynch has sports psychologists, as does Dr. Levine at Columbia, that if these kids get identified as, scoring low on these return to sport indices, after their ACL surgery is done, they've recovered, they've rehabbed, and their knee feels great, they have resources to get set up with a sports psychologist to help them work through some of those fear components. Part of it might just be they need more time, but if you have resources like that available to the teams, which the higher levels do, it's a great option for these kids. Someone just to talk to about that fear and validating it.
Robbie, I'll tell you that as an orthopedic surgeon, whether you go into sports medicine or not, what you find out very early in your practice is that you spend maybe 90% of your time as team psychologist or team psychiatrist for your patients.
Yep.
And all that's not joking. I mean, we honestly, you know, we have the easiest part of our job, and that's why we love what we do. Like the surgical part of what Dr. Redler shared with you, you see how passionate she is about it, and that she's so good at it, and it's great. But the hard part, as we tell our patients, is the rehab. And so we do a lot of cheerleading. We do a lot of armchair psychiatry and psychology. And of course, sometimes we actually do need the professionals that Dr. Redler mentioned. But we do a lot of that on our own. And that's not just if you're a team physician. If you're taking care of total joint patients, God, if you're a spine surgeon, you're doing that like for 99% of your patients because they all wonder if they're ever going to get better. So it's pretty impressive and important part of what we do. All right, everybody, thanks very much. Next Monday, we have our 7th Ortho Mentor webinar on the virtual interviews, where I think we just tipped 1,000 registrants, so that's cool. And look forward to seeing you there if you can. If you haven't got your Loom Cubes or your O-rings or whatever light sources you've gotten, Matt Levitsky, you better get one, man, because you're terrible. But make sure you start thinking about your lighting, your background, and that you've got a very good room in which to do all your interviews so that you're not getting dogs barking, kids screaming, and whatever else. You don't want to be interrupted during the interviews. Dr. Redler, thank you so much. That was awesome.
Thank you, guys.
And congrats to everybody. And we'll see you all next Monday and then 2 weeks for our last clip session. Thanks, everybody.